My name is Stephanie Lesage. I'm the educator in internal medicine at the Glen, and Dorothy is going to be helping me with the presentation today. So we're going to talk about working with an LPN. So the big question is, what can an LPN do? That's always the question on everybody's lips. How can they actually help me? And everything about that is in the reference guide. That's what Dorothy's going to be covering. But before we start talking about what they can and cannot do, the specifics of it, you have to know how to work with an LPN. So the three topics, the three big things about working with an LPN is collaboration, delegation, and communications. Those are the three words to remember. We're going to show you a few videos about the LPN and the RN dyad. We're going to talk about those three key points. I'm going to show you some of the video for the LPN Code of Ethics. So all these videos are available on the ENA site for those. You can get them there. The clarification of roles, we're going to compare the LPN and the RN in terms of what they can and cannot do. And then there's the video on the reserved acts. And Dorothy's going to cover the reference guide. And we're going to go over some case scenarios. So we'll start off with the dyad video. So we'll get to the three pillars, if you will. Collaboration, so it's founded on common goals for your patient. Whatever it is you have to do with your patient that day, maybe it's mobilize the patient, get them sitting up in the chair, get any drains removed, anything like that. Just so as long as you're on the same page, you both have the same goals. It requires an open and continuous dialogue, so constantly speaking to each other throughout the day, making sure that you're doing everything that needs to be done, that you all understand what needs to be done. Requires an understanding of the roles and responsibilities. So for the nurse to understand what her role is and to also understand what the LPN's role is, and then vice versa. We have to know what we can and cannot delegate to the nurse, to the LPN, and what we should do for ourselves. And it's not intuitive. Don't expect this to be perfect from the get-go. It's going to take some time to get used to working with them and to kind of work things out. So delegation is about working with people to accomplish more than one person can do alone. And it's the transfer of responsibility for the performance of patient care while retaining accountability for the outcome. Does this mean anything to anybody? Do you have any reactions to this? Any thoughts or feelings at all?
I think it's the word accountability.
Mm-hmm. Yeah. And that's a scary thing. I know when I've taught this before, that's always the thing. Well, I'm accountable for anything she does. The LPN's going to make a mistake and it's going to be my fault. It's something that is very common. I can understand the feelings, the word accountability. I'm accountable for everything that happens to this patient. You have to remember that, yes, you are accountable for delegating the task, but the LPN is also responsible for accepting that delegation. If she accepted something that she shouldn't be doing, and you delegated something that she shouldn't be doing, and she does it anyways, it's her responsibility when it comes down to it. Like you saw in the video that the patient was given their food when they were supposed to be NPO for a test. Now, yes, it is the nurse's responsibility to make sure the following care that comes from that occurs. So the patient's test is probably going to have to be canceled. We might have to start the NPO again. It's up to the nurse to see, maybe did I delegate incorrectly, or was I misunderstood, or sometimes mistakes just happen. The PAB could have been the one to give the tray. And you might have had that before. I know I've certainly had that before, but I'm not responsible for the PAB's actions if I delegated appropriately. So it's important to remember that the LPN accepted the delegation. Are you allowed to do blood gases, or arterial blood gases? You ever had a resident ask you to do an arterial blood gas? I certainly have. It was my responsibility to say, no, I don't do that. It's up to you to do that. But if I had done it, regardless of whether I should have been doing it or not, it would have been my responsibility, because I would have done something incorrect and not within my scope of practice. So it's not, you're not responsible for everything they do. They were oriented. they have their own scope of practice, and so they have to be responsible for their own actions. If they're doing it when they don't know what they're doing.
And also if they do it and do it improperly, it's important to know that it falls under their license, as long as you delegate it appropriately.
Yeah, so that's why appropriate delegation and appropriate communication are very, very important. Delegation, there's a lot of fears that come in, as we talked about this in the video. So I'm giving up control when I'm accountable, when everything that they do is now out of my control. You like primary nursing, where everything is just my responsibility. I'll take care of it, I can do it, I'm super nurse, I'll do it all. How am I supposed to trust what somebody else is doing? And are you going to be blamed if anything goes wrong? So yes, you do have to trust that everything will be okay, but this person went through orientation and they have their own license, they passed an exam, and they're responsible for saying, just like anybody, I don't know how to do this, I need help. Just like your new CEPs who are on the unit, they're going to be covering you during break time. They will have gone through orientation. If they don't know when to ask for help and when to go get help, you trust that they hopefully know that. They're covering you for the 45 minutes or an hour that you're gone. You hope that they know. And if they don't, they have to ask. So it's important to focus on what the nurse is accountable for and to let the delegate also assume, so the LPN to also assume their level of responsibility. There are some things, though, that the nurse is specifically responsible for, so the assessment of your patient. Now, the ideal thing that happens is that you go into the room at the same time, and that's because the nurse has to have a point of reference when it comes to the patient's assessment. So the minimum that has to be done is a focused assessment. So it's the presenting problem of the patient. Chances are it's going to be a neuro assessment in your case. So the initial neuro assessment would have to be done by the nurse. Any subsequent neuro assessments for a stable patient can be done by the LPN. That's fine. But if something were to happen with the patient, the nurse has to have an idea of what the patient looked like before. So that's why that initial assessment is very important that the nurse do it. So ideally you go in together, the LPN maybe is doing the vitals, checking the blood sugar, and the nurse is doing the head-to-toe assessment. But the minimum is that focused assessment for whatever the issue, the presenting issue is.
And the LPN should see it with you too, right? Because they want to know what the initial assessment was like as well.
Yeah.
And then the nurse is responsible for documenting that neuro assessment, right?
That's the most important part, and yeah, documentation is something very important. You document what you did. And that's in any case, any patient, whether you be working with an LPN or not, you document what you did. So if you did the head-to-toe assessment, that's what you're documenting. If your LPN happened to do it, that's great. They can document it as well. You're not double charting what they've already charted, nor are you reading it to verify that the information is correct. You're not co-signing like you might with a student to make sure that everything got done. You might read it though, because you're filling in the blanks that they necessarily didn't do, didn't see. So it's, charting is a shared responsibility, yeah. The decision to delegate stays with the nurse. She's the one responsible for the overall care of the patient. She needs to know what's going on with the patient. Shared goals need to be met, so you need to know what the priorities are for the patient. You need to provide clear direction, because without that, nobody knows what you're thinking. So you need to be clear with what you say, and to follow up on the completion and ask for feedback. So it's constantly throughout the day you have to be asking questions to make sure everything is okay. Now that being said, it is also the LPN's responsibility to come find you if something is abnormal or something needs to be reported. It is a two-way street. You're responsible for asking, they're responsible for telling. So the 5 rights of delegation, that was in the little video. So is it the right task? Is it within their scope of practice? Is it under the right circumstances? So they, general rules that LPNs don't do the firsts on your unit. So they're not going to do the first post-op dressing. They're not going to do the first trach care on the unit. The first neuro assessment, they're not going to be doing that. If the patient is deemed stable, they can do other ones, but that first one needs to be done by the nurse. Is it to the right person? The LPN, the RN, or the PAB could all get a delegation, depending on what their role is. Everybody in that list can do a bed bath, but not everybody is assessing the same things. The PAB is essentially washing the patient. assuring their comfort. The LPN might be applying creams to the patient after the bath is done. They might be changing a coccyx dressing, whereas the RN helping with the bed bath might be assessing their mobilization. It's assessing all of their skin, checking to see how they follow commands, if they're able to turn by themselves, or if they're able to help you out in some way, cross their arms, whatever it may be. Is it with the right communication, so the initial directions and then those check-ins throughout the day, and with the right supervision and evaluation. So throughout the day, maybe just ask, did we miss anything? Just kind of reevaluate what you've been doing with this patient and see if everybody has the correct information. The 6 C's were also in that little video. So is it clear about what the goal is for the patient? Is it concise? Did you just throw a whole bunch of information at the LPN and expect them to know what to do with it? Or were you a little bit more succinct and focused in your words? Is it correct? Does it fit within their scope of practice again? Is it complete? Do they have all the tools necessary and all the information necessary to complete this task? So if they have to do ins and outs and bladder residuals, well, do they know that the Foley was removed a little while ago at 6 a.m.? Do they have this information that maybe will help fill in the blanks and also kind of make them understand the importance of doing those ins and outs? Confirm, so make sure that everything is clear, and then that come back, ask them to come throughout the day and tell you how maybe the results of those, the bladder scan was. So principles of when working in a dyad, the RN is responsible for the overall care and its appropriate delegation. The LPN works independently, okay? You don't have to follow after them. They're not like a nursing student where we have to watch them and assess them and make sure everything's okay. During orientation, yes, most certainly. But once you work with an LPN, they really are independent. You know, I'd like you to do the vital signs and the blood sugars for all these patients. They'll go do it and they'll come back to you with results when it's done. Okay? Remember that an LPN needs to follow a plan or medical order. That's why the PTI is particularly important for the nurses to fill out. I know it's not ideal everywhere throughout the MUHC. That's one of the things that will help the LPN do their job properly. It really is all that nursing theory and process that we have in our head put on paper, and it's something for them to follow. Some guidelines for them. And the same things with the medical orders. So although they're not the ones who transcribe the medical orders, they do need, just like we do, medical orders to complete certain tasks. And the LPN is responsible to report, and the RN is responsible to ask, make sure everything was okay. Communication is crucial in pretty much any relationship you have. So the LPN is no different. Shared consensus, a census about going to see your patients, essentially. So going to see your patients in the morning, getting report together is important as well, and going to see those patients and introducing yourself to your patients as the RN and the LPN. Huddling to constantly see throughout the day, make sure everything's okay and you're both headed in the same direction. To set your priorities, maybe it's the dressing change that needs to be done for that patient. The RN needs to see the dressing change, but the LPN is going to do it. So let's set a time to say that we're going to go in at 10 o'clock and we're going to go do it together. Maybe it's a change in protocol that needs to be done, a reassessment. The LPN can do the new dressing, but the RN has to say, well, this change, we're going to be doing it. So Dorothy's going to be covering specifics like that a little bit later. And we need to focus on what are the outcomes. What do we want to achieve for these patients? So there was an OIIAQ audit back in January of 2019, and there were several NPDEs who followed dyads a few months beforehand, and there were things that came out of those audits that the NPDEs did that kind of helped us reorganize the way we do things for this inspection that was going to be happening. So one thing that wasn't always happening was that RNs were not always doing the minimum of focused assessment. You need to be able to go see your patient. You need to have a baseline for that patient. That didn't always happen back then. That was something that we needed to work on. So that's something that needs to be, just make sure that everybody is, that the nurse is well aware of what's happening. The RN needs to write something, so that wasn't always clear. So you have charting by exception. That's a great place. The nurse has to fill out something on that sheet. It's even if you have a super stable patient who the LPN could do absolutely everything on, all you basically did was you introduced yourself to the patient and you did your small focused assessment. Well, the nurse needs to at least chart on that focused assessment, okay? And anything else that you may have done with that patient throughout the day. Teaching can be done by the LPN based on written material. So let's say you have a newly diabetic patient. Well, the RN is probably going to go introduce the topic, maybe perform some techniques on an injection, provide them with some information. The LPN can further that teaching. We have a lot of information on diabetic teaching, and the LPN can certainly continue that. And one of the last things that was a little bit confusing for people was the Morse and the CAT. So the Morse is essentially data collection on how the patient, here's answering questions like, does the patient have an IV, and they have previous falls. You're just answering questions. The LPN can do that. The CAT, on the other hand, is about putting in place interventions. So that really has to be filled out by the nurse. So a lot of times we were seeing Morses that were filled out, but not CATs, because the LPN was filling out the Morse, but they don't fill out the CAT. Any questions so far? Okay. I'm going to show you the Code of Ethics, part of the Code of Ethics video on the internet. There's a lot of the same stuff as nurses. We're not going to give medications if we don't have the proper information. We're not going to falsify any documents or omit things. It's a lot of the same stuff that we would do, and they have the same responsibilities. That's why I just wanted to show that to you, that we don't have to necessarily worry all the time about what are they doing with the patients. They're there to take care of the patients just as much as we are. So this is one of the documents that is available. It compares the LPN and the nurse role. It is in this binder. All the information that is available on the internet is available in these binders. So that'll be on your unit. So it really just compares, and that's what we're going to be going through right now. So patient care assignments, so the LPN and the RN really do share their assignment, and the LPN, it's really within their scope of practice. And the nurse rather is the team leader, if you will, and is responsible for the delegation of the tasks. The PTI, it can't be initiated or adjusted or adapted by the LPN. They really have to follow the directives that are there for them, that are written. They can suggest things to you. It's much appreciated, in fact, but they're not actually going to be the ones that change it. You have to agree to it, essentially. That's the nursing tool. And so the nurse is responsible for adjusting that tool. An LPN is not going to be in charge, nor should an LPN be left alone on the unit. They always have to have a nurse of reference. So it may not necessarily be the nurse that they're working with. It can be another nurse who's on the unit who's covering for that first nurse. And the nurses can be in charge, then they're responsible for ensuring the proper coverage of the unit. Transcription of orders, that is not done. It is not done by the LPN. The transcription of orders is really the responsibility of the nurses, and that's because when you're transcribing an order, you're also evaluating whether it's appropriate for the patient, and that is a very important step that needs to be done by the nurse. They can tell you an order is there, that's lovely, but they're not actually going to be the ones to transcribe it. Verbal orders, telephone orders are a no for LPNs, and an RN is responsible for doing that. An LPN, it's up to the LPN though. If a physician comes and gives them a verbal order, it's up to them to say, you really have to go write that down or talk to the nurse. Okay? It's for them to do that. Medication administration, they can administer all medications except for IV medications, and it really is IVs with additives. So they could give NS, D5, D5-half NS, Ringer's lactate, but as soon as you put that 20 megs of KCl in that bag, it's an additive and they can't give it anymore. They couldn't give Pantaluc IV, they can't give an antibiotic IV. They can give opioids though. They're responsible for knowing the side effects of these medications when they give them and what they should be looking out for. They can insert butterflies as subcutaneous needles. They can do a double identifier. They can do independent double checks with an RN, not with a CEPI, but with an RN it's fine. They can carry narcotic keys. They can participate in narcotic counts, again with an RN. And the RN is within her scope of practice. More on medications, so if they can pick up restricted meds at the pharmacy if that's needed. You have PCAs on your unit. They don't touch PCAs, nor do they do the double verification of a PCA because they don't give the medication in the first place. It's IV meds, they don't give it. Blood transfusions. So this is an important one. They can do the double patient identifier, check the bracelet. They, however, cannot check that green sheet with you unless there's no other RN available. So in exceptional circumstances, yes, they can check it. But otherwise, if there's another RN on the unit, it has to be checked with another RN. They can only monitor after the first 15 minutes. That first 15 minutes really is the responsibility of the nurse. Beyond that, they can check the patient, make sure everything's going okay, but not for that first 15 minutes. They can't stop temporarily, they can't initiate, and they can't discontinue that blood transfusion. It's an IV medication, actually. The nurse is responsible for the blood transfusion, getting the consent, and administering, especially the first 15 minutes of verification, because that's when the patient's the most critical, right? So that's the nurse's responsibility. LPNs can insert IVs, and they can give NS, D5, D5, ringers. They can't adjust the rate without a medical order. So even if it's for the NS, they can't decide they want to put the continuous IV at 30 cc's an hour. They need an order for that. The nurse has a responsibility to do that. Central venous access devices, LPNs don't touch. They don't change dressings, they don't remove central lines, and they don't do blood procurement from central lines. And the nurse has the responsibility to do that. Wound care management. So if you filled out your wound care sheet properly, the LPN can follow that wound care sheet. That's no problem. She can go do the dressing. They don't do the first post-op dressings. Again, it's the first thing that one of those first they don't do. They don't do VAC dressings. They don't manage dialysis catheters, and they don't remove or apply compression dressings. They, however, can swab the wound. And they can remove staples or sutures from a wound. So let's say you had a dressing that, as I was talking about before, you want to go do with the patient, for the patient, and maybe the nurse needs to come assess the wound to make sure everything's okay. If the nurse wanted to change the wound dressing that was going to be applied, she could tell the LPN what needed to be changed, and the LPN could then do it. But that change rather has to come from the nurse. Ostomy care, so they can empty the bag, they can change it. They're just not within the first 72 hours, and again, not the first change on the unit. So when it's a fresh ostomy. Foley's, they can insert, change, remove Foley's. They can measure the urine output. They don't insert coups, and they don't monitor CBIs, so consequently they don't insert three-way Foley's. And they don't monitor CBIs because it requires an assessment to see the clarity of the fluid, so to
Can
adjust.
they flush a Foley if it's blocked?
Yeah. Trach care. So they can do trach care at the MUHC, just not within the first 48 hours of that fresh trach. They can do suctioning, but again, for the trach care and for the suctioning, it's not the first one on the unit. So you get a fresh patient, you're not going to be suctioning them. A patient who is on a ventilator, who has a trach, they don't suction either because they don't deal with patients, or they don't take care of the ventilator, so no suctioning. They don't install passing mure valves or corks, and they don't inflate or deflate the balloon. Feeding, so they can give medications through feeding, the drop-off, whatever, it may be a peg, that's no problem. They do adjust those pumps, and they can do gastric residuals. So there is some things that might need to be reported to the nurse. Let's say your gastric residual was above your allowed level. They would then have to go report that back to the nurse and see what needs to be done. But essentially, they can do all those things.
They can insert NGs also, right?
Yeah. CVP, or any hemodynamic monitoring. they don't do. That's the nurse's responsibility. The same with ICPs and EBDs. They don't do them. It's great for them to have the knowledge of what it is and that they shouldn't be adjusting the bed level and a general idea of what that patient has, but they're essentially not going to be the ones that are really touching that. Documentation, we made mention of before, it's really a shared responsibility. Whatever you did, you document. It's like that for any patient. If you didn't document it, you didn't do it. So really important that you chart what you did. Okay. Patient teaching, I mentioned before, the LPN has to do it based on material that we have. So the RN is probably going to start the teaching, and then the LPN can always go finish anything based on material. So if we have material, then we can do it. For discharges, one thing to mention for discharges is that a prescription, even though it's written, is not an official written material. The discharge teaching on medications really has to be with the nurse. Okay, same for any follow-up appointments or anything like that. The LPN can assist with discharges, maybe by removing the IV and making sure everything else is taken care of with the patient, but they're not going to be the ones to do that envelope teaching.
And I think what's important also to know for our floors, because we have a lot of post-ops that will come and go, it's the nurse that makes the decision of whether the patient can be transferred. So that's why the nurse also has to assess those patients, even if they're super stable and they're walking and they're ready to go.
That's the nurse's decision. Patient, yeah. And so that's why the nurse has to be the one to see the patient. And another important thing that happens when you hand that envelope. I'm going to show the last video here for the reserved acts, and then Dorothy's going to be taking over with the acts.
Thank you. Perfect. So, so this is really just going to reiterate what Stephanie has already presented. We're just going to, because this reference guide is in the yellow binder, I wanted to show you what it looked like inside. And we'll go through the 9 reserve acts. I'm not really going into, there's actually more than 2 authorized acts. There's like 9 of them, but I didn't go into that, and the nurses can look through it later. So this was adapted from the reference guide that was made by Amelie Ribach and Sonia Tukat. The guiding principles: the licensed practical nurse, the LPN, must acquire the required skills to work in a clinical environment. If an LPN does not have the required skills which necessitate a certificate from the OIIAQ, she must contact her immediate supervisor. The LPN is responsible to notify the nurse if she needs support in performing any activities which are within her scope of practice. So if the RN delegates a certain act for her and she says, yes, no problem, but then she doesn't tell the RN that she actually is not comfortable, doesn't really know, is not licensed to do it, then she actually is accountable now that she has taken it on, and it's her responsibility to share her discomfort with something. LPNs who have graduated before 2009 are required to obtain an OIIAQ certificate to perform these following activities: the blood procurement, the vaccination, nasogastric insertion and care, and intravenous insertion and care. So the LPNs who graduate after that, it's no problem.
You said 2009?
Yeah.
Yes.
Okay. So they were not doing that before that?
I think that back then it was kind of like not as monitored, and maybe some of them were doing it, but they weren't supposed to. And now, so even though a lot of them, let's say they have started IVs and they've been starting IVs for a long time, but they actually did not get any certification for it, now we're going backwards and saying we need the certification.
Okay.
The following activities are not part of the basic training of an LPN and do require a specific training and certificate from the OIIAQ. So that's a maintenance care tracheostomy connected to a ventilator, and as Jessica said, she's going to eventually get all the LPNs certified for that. And the immobilisation plâtrée, I don't know if we have that here at the Neuro.
What is that?
I guess it's with a
Oh, cast?
the cast, yeah.
No.
So if they have a patient with a cast, what can they
No,
not?
it's to apply the cast.
Oh, yeah, well, I wouldn't even know how to do that.
Me neither. Okay, so now we're going to go into the licensed practical nurses, the LPN's reserved clinical activities. There are 9. This, I wanted to just go through the 9 first, repeat what was presented by Jessica. So the 9 activities reserved for LPNs of the professional codes are: 1, apply invasive measures for the maintenance of therapeutic equipment. 2, take specimens according to a prescription. 3, provide care and treatment for wounds and alterations of the skin and teguments according to a prescription or a nursing plan. Observe the state of consciousness of a person and monitor neurological signs. 5, mix substances to complete the preparation of a medication according to a prescription. 6, administer prescribed medications or other prescribed substances via routes other than the intravenous routes. Participate in vaccination operations under the Public Health Act. 8, introduce an instrument or a finger according to a prescription beyond the nasovestibular, labia majora, urinary meatus, or anal margin, or into an artificial opening in the human body. And 9, introduce an instrument according to a prescription into a peripheral vein in order to take a specimen, provided a training certificate has been issued to the member by the order pursuant to a regulation under paragraph, etc., etc.
Do you guys usually get orders to insert IVs? Do they write it in the chart?
Sometimes.
If it's to start infusion.
Okay, so then they would definitely have to be clearly written in the chart for an LPN.
It's not always written.
Sometimes we get a verbal order, or sometimes they just write it.
Okay.
Not all the time.
Because if they say start NS but there's no IV, you know you have to put in an IV.
Yeah.
But if it's not written, insert an IV in the chart, then the LPN shouldn't.
But the nurse can take the verbal order from the doctor, write it down, and then the LPN can do it once you've delegated it to her.
The other thing too, so for monitoring neurological signs, they have extensive training on monitoring neurological signs. So a lot of the LPNs that we're getting, in fact, none of them have worked in neuro before, the
Okay.
new ones that are coming. So will they be like quite advanced in neurological assessment? We'll have to retrain them?
But it's much like a new nurse who starts, who maybe doesn't have basic, who
Neuros
went
experience.
through it in school, yes, but doesn't have the specifics maybe that are required here, the level that is required here. So that
Okay.
really needs to be shown during orientation.
Yeah, so maybe, do they have like 2 days of, how many days of orientation?
They get 2 weeks.
Oh, 2 weeks. Okay.
Yeah.
So fit it into that. So this is what the first reserved clinical activity page looks like for applying invasive measures for the maintenance of therapeutic equipment. I'm going to zoom in the clinical activities, the conditions of practice, and the restrictions. So the first one, the clinical activities, ensures maintenance, the irrigation, the flushing, etc., or therapeutic equipment used for patient to treat the catheter, urinary catheter, the PEG, the double-off rectal tube, the drains, the Jackson-Pratt chemovac. The conditions of practice, this is going to be pretty repetitive. They have to follow the medical order, follow procedures in effect, and follow instructions indicated on the PTI. The restrictions, they are not authorized to perform maintenance of therapeutic material used for pleural tubes and collection devices, negative pressure therapy dressing, VACs, PICOs, etc., the epidural catheter, the PCA pump, and the EBDs. There are also clinical activities for ensuring maintenance of irrigation and emptying of ostomies, urostomies, colostomies, and ileostomies. Again, the conditions of practice, they must notify the nurse if there's any changes that are observed. They follow the medical order, the protocols, and the instructions on the PTI. Restrictions, they're not authorized to do the first change of the ostomy device. They're not authorized to care for fresh ostomies within the first 72 hours post-op, including the emptying and the dressing change, and they're not authorized to change a collection device. Page 2 of the reserved clinical activities, I crossed out the bottom half because it's only for the Lachine nurses. So for taking specimens according to prescription. The clinical activities are retrieving the following specimens. They can retrieve specimens from capillary puncture, urine, stool, secretions, throat, eyes, ears, nose, anus, vagina, wound secretions, sputum, conjunctival secretions, including nasopharyngeal aspirates. The same conditions of practice, following the medical order, the procedures in effect, and the instructions on the PTI. The restrictions, they are not authorized to collect the pleural, peritoneal, or cerebrospinal fluid specimen. I'm going to skip through these. And the third reserved clinical activity for inserting an instrument according to a prescription into a peripheral vein for the purpose of collecting a specimen. So they can collect blood samples from a peripheral vein. Conditions of practice, they may need a certification if they were here before 2009.
I said before that they can't take blood from an IV.
Yeah, so they can take it from an IV that's in place, but they can do a venipuncture.
Okay. Do you know why they can't take it from an IV? What's the difference?
I would assume that maybe it could block.
I know that when they initially insert the IV and you take your bloods, that's fine.
That's
Yeah,
fine?
that's
Okay.
Insertion, but,
Okay.
but afterwards, once
Okay.
it's inserted.
Okay, that's what I was wondering, because before I said it from a CVAD or from a peripheral IV, so I was wondering when they insert it, they can take bloods at the same time.
Yeah, so that's kind of like a venipuncture, so I think that they can do it, but
Okay.
after that, yeah.
Okay, because it would have been a weird thing that they can't do.
Okay, so the restrictions, they are not authorized to collect a sample from an IV from larger than an IV, so not from a portacath or a PICC line. And they're not authorized to perform bleeding phlebotomies, therapeutic
So PICC
phlebotomies.
lines too, nothing from a PICC line.
No. I think the whole idea is behind the risk of blockage. Fourth, reserved clinical activity for providing care and treatments related to wounds. It says related to wounds, alterations of the skin and teguments according to prescription or the therapeutic medicine plan. The initial wound assessment must be done by the nurse. So like Stephanie said, the initial anything. Initial suction, initial anytime the patient comes, so.
But they can fill out the Braden scale.
Yes. Well, the nurse does the initial, the nurse has to do at least a focused assessment, so the LPN can also do that. But the LPN usually does a full head to toe, and the nurse can sometimes just do the focused assessment. Activities also for providing care and treatment related to wounds, they contribute to the assessment of wounds and alterations of the skin. And they can help out the nurse, they can bring observations to her attention. They apply the following dressings: the wet or dry dressing, aseptic dressing with a wick or a drain, removing staples or sutures, applying alignment stitches like Steri-strips or adhesive bandages, using substances that facilitate wound debridement. They also are authorized to apply the initial post-op dressing in collaboration with the nurse. So they can't do the initial post-op dressing on their own, but if the nurse is present. Conditions: the initial wound assessment must be done by the nurse. The wound assessment is the nurse's responsibility, and they must notify the nurse if there are any changes observed. Not authorized to apply dressing over a central line, like a dialysis, a PICC line, jugular, subclavian, or portacath. They're not authorized to change the dressing for the drains in the pleural space, like the chest tube or the pigtail or the perex. Not authorized to apply or remove a pressure dressing, or to change a dressing related to negative pressure, like VAC and PICO. Not authorized to apply and monitor leech therapy. Not authorized to perform mechanical wound debridement, nor to care for fresh ostomies within 72 hours in the first 72 hours post-op, including the emptying collection device or the dressing change. The fifth one, observing a patient's level of consciousness and monitoring neurological signs. Zooming in, they observe neurological signs, the parameters, and the reactions in a stable patient. And they contribute to the assessment of the level of consciousness using the proper scale in effect.
And for vital signs too, if the vital signs are not there stable, they should be not caring for that patient anymore, right? If they become septic,
they would
if
take
they
the initial
become,
vital, it's not normal, so right away they would let the nurse know so that she can then decide on the plan of action, and they're working together as a team, right? So then the nurse can either tell her, okay, this is what we need to do next, you're capable of doing that, or she can say, okay, needs my immediate attention, could you watch my other patients, or I'm in the middle of addressing, can you just take over and finish up while I go and take care of this suddenly unstable patient?
because we're not supposed to take care of hemodynamically unstable patients as well, right?
Yeah, so what Dorothy just said is accurate, yeah, and the LPN can assist with, let's say, tasks on that unstable
Yeah.
patient, maybe taking a blood sugar or something, but ultimately, the nurse often remains focused on that patient who is unstable, yes, and then the LPN can either help with tasks on that patient or help with all the other patients.
They can work like as a team on the same patient if there's nothing pressing elsewhere. If there is, then they'll divvy up, but otherwise they can both do many things at once.
Okay.
And that's the advantage of having this working out with 8 patients for 2 nurses, because you have more hands working on for the same patient. Conditions of practice, so delegating the neurological monitoring is based on the patient's condition, and that's the nurse's responsibility to decide at what point she can advance. Restrictions, they are not authorized to monitor the neurological signs or the level of consciousness in a patient whose condition is considered clinically unstable or with a suspected trauma injury after a fall.
That's really important to emphasize in this training, because we have a lot of falls.
Okay,
So when the
Yeah.
patients fall, it'll have to be the nurse that
right,
does
a
that.
change in condition, so you need a brand new initial assessment after an event. So the 6th one, mixing substances to complete the preparation of a medication according to a prescription. They mix substances when required for medication preparations, including insulin and any other substance that the LPN is legally authorized to administer. Conditions, they follow the medical order, in CMAR, they follow the protocols in effect, and they follow the instructions in the PTI. So this, again, all this repetitive PTI is to emphasize to the nurse that when they're working together with the LPNs now, it's very important to keep the PTIs up to date for the LPNs to follow. I know that it's kind of not used as much as, for example, the ADL flow sheets. The restrictions, they're not authorized to prepare or perform the independent double check or verification for medications that the LPN is not legally authorized to administer, except for blood products in exceptional situations. And not authorized to administer the medication regulated by a collective order without first having the patient assessed by a nurse, and without the nurse's authorization to apply the collective order and documentation of the order in the CMAR or medication sheets by the nurse. The 7th, reserved clinical activity, administering prescribed medication or other prescribed substances via routes other than intravenous, repetitive, the oral, sublingual, subcutaneous, including butterfly, intramuscular, topical, transdermal, ophthalmic, auricular, inhalation, nebulizer, intrarectal, and vaginal. Other clinical activities include enteral feeding or medication via the nasogastric tube, ostomy, gastrostomy, jejunostomy, colostomy, and dab-off. And they are authorized to insert and flush a butterfly subcutaneous infusion set. Conditions of practice, follow the order in CMAR, follow the preparation protocols, follow the instructions in PTI. They can measure the gastric residuals, and they can set up and use a feeding to follow the protocols in effect. Restrictions, not authorized to administer blood products, including immunoglobulin, via subcutaneous and intramuscular routes. Not authorized to administer medications intravenously via the following routes: pump, microinfusion set, and syringe driver. Some more reserved clinical activities for the prescribed medication. There is chemo, oral, contributes to the assessment of adverse effects, toxicity, and symptoms related to treatment, and communicates observations to the nurse. Conditions. Assessment of the patient's condition prior to administration of medication is the RN's responsibility. Assessment of adverse effects, toxicity, and symptoms related to treatment are also the RN's responsibility. Restriction, not authorized to administer chemo using any other route other than oral. Also, they can process the verification of blood products. As for protocol, they can verify the blood products as one of two verifiers with an RN only in exceptional situations when another RN is not available on the unit. The eighth one, contributing to vaccinations.
We don't do that here.
We can skip right through. The ninth and last one, inserting an instrument or finger according to prescription beyond the nasal vestibule, labia, majora, etc. They can provide care related to bladder elimination, insert, changes, or removes an indwelling catheter, performs a urinary catheterization, and performs the bladder lavage. Again, the same conditions of practice to follow the PTI and follow the medical order. Restrictions, not authorized to insert a catheter to perform the bladder catheterization or bladder lavage in a patient having recently undergone urinary surgery. And they're not authorized to install or change a Coude catheter or a suprapubic catheter. So these were some of the questions that came from the quizzes that were sent out to the nurses. First of all, were there any questions besides? No, we just reviewed the 9. Okay, so we sent out the 2 parts of the quiz, which were 20 questions, and the questions that came back: can LPNs care for patients with the EBD? Can an LPN suction a patient with a ventilator, or can the LPN have a trach patient? And can LPNs follow up on blood results in OASIS? Other questions: provide more information on their scope of practice. There are not enough resources to refer to. How to divide care in the daily routines. What charting needs to be done by whom, and how to minimize charts. So, can LPNs care for patients with EBDs? No.
Well, they can, but they can't touch the EBD, right?
Exactly. I mean, they can do other stuff. They can take vitals. They can give baths. They can get them up. Well, EBD, no, they cannot change the position of the patient. So, on the first question of the reserved clinical acts, the first one for applying invasive measures, zooming in down to the external ventricular drain. They are not authorized to perform maintenance of therapeutic material used for external ventricular drain. But they cannot adjust anything on the EBD. They cannot help the patient to sit or to stand unless the RN is there to adjust the EBD. They can bathe the patient if the position is maintained, not sitting up and lying down. And same thing, the medications, if they give a medication that the patient doesn't change position, then it's okay. But if they're going to have them sit up to swallow a pill or something, then they can't. And so the RN must consider all these things before she delegates any tasks. So the LPN suction a patient with a ventilator, or can the LPN have a trach patient?
They can suction, you already answered that. They can suction if it's not vent patient.
Right.
But if it's not new, so it's not a new trick like past 48 hours.
Right.
What if they downsize the trach? What if it's an existing trach that has gone and they've now, sometimes they go for trach changes when they stay a long time, or they'll downsize the trach.
Kind of like weaning them off.
The downside is fine, it's really
Yeah.
just the fresh hole.
Okay, so if there's a trach change or a downsize, they can suction.
Yeah.
So this was found in the authorized, the second part of the reference guide. It was in the second one, and we'll zoom in. For the tracheostomy care, they can perform care related to the tracheostomy, they can clean the internal cannula, perform dressing change, including the strings, and suction secretions via a tracheostomy. The certification may be required if it's from before 2009, and they'll respect the medical order, follow the protocols, follow the PTI, but not if the patient has a ventilator and not within the first 48 hours, as you said. They're not authorized to perform the initial suction following the unit transfer, and they're not authorized to put a cork, a plasminoid cork. And they're not authorized to inflate or deflate the tracheal cannula bag, except if they're in a long-term care. The third one, can LPNs follow up on blood results in the OASIS? Yes, they can, but like any abnormal vital sign, they must communicate the results to the RN. If there's follow-up action needed, the RN can give instructions or authorization for those acts. The other questions? Provide more information on their scope of practice. There are not enough resources to refer to. So this is the resource that we're going to have, the yellow binder with all the information from the internet, or you can go to the internet and all the information is there as well.
When you said the internet, the MUHC website or?
Yes, the MUHC portal.
So what do we go under?
You go under
LPNs?
collaboration, team collaboration, and then you go under nursing, and then you go under professional practice.
Okay.
I'll show you. It's a couple clicks. What was I gonna say about? Okay. No, I forgot. Okay, in Oasis, I'm assuming that they can't enter swab like MRSA swabs, very swabs. No, because it's a verbal order type
cannot.
of thing. No.
Okay, and how to divide care in the daily routines? What do you guys think? You have 8 patients and you're 2 nurses.
Well, the more critical, for me, I'll think that the more critical one will be the ends, and then still you can delegate the task that the LPN can do.
So it's important to know, for both of you to know what you can and cannot do. And you can take it from there.
I think it's really important
Oops,
to
sorry.
know, because I think doing the rounds everybody together is a really good point. Like in the morning
Yeah.
to start out the day together, and maybe while you're doing your neuro assessment, like the LPN should also be involved, but then, you know, they can be doing the vital signs like you said while they're
Yeah.
doing it, and then you can say afterwards, okay, so this patient's not looking great, I'm gonna focus on this patient, can you go do the other vital signs or do the medication administration for these 5, and I'm gonna focus on these 3 because they look more sick. And
Yeah, and it's important to just explain, well, decide together also so that the LPN knows what you're doing as well. Because, well, just to know so that both nurses understand their patients, what's going on for everything. And then, like Jessica said, you decide together on how to equalize it. And like on one day, you might ask the LPN to do vitals on 5 of the patients, and the RN will do it on 3. But then on another day, you might have heavier patients, so then it might be all 8 vitals, or well, not the heavier patients, but let's say all 7 vitals, or so forth. And just really depends. So that's why it has to be a constant discussion and constant communication. And even throughout the day, as things change, as you get admissions or whatever, then you might have to just reevaluate what your original plan was and change it a little bit to adjust it to be able to care for the patients.
And it's important, I think the LPN knows what's going on, even if you're focusing, let's say, on 3 of the patients more, and they're focusing on the other 5, the LPN needs to know what's happening with your patients too, because if something changes in the assignment, all of a sudden you need to pick up another one of theirs, they might need to focus more on some of your patients you were looking more at, and then they won't be able to if they're starting off fresh. And it's easier for them to cover you when you're on break if they know everybody.
Yeah, and also like when you have the admission, if it's possible for both of you to be together, you might as well both of you assess at the same time so you know what's going on, instead of because you were busy in another room with another patient. Later on, the RN has to give a report to let you know the new patient is this. But there's that constant communication going on. So what charting needs to be done by whom, and how to minimize
Like
charting?
you said, the focus assessment.
Yeah.
by the nurse, and then the LPN can do her part after assessing the patient.
So anything that you do, any action that you have taken, each person will chart their own part.
But by the charting by exception sheet for the nurse, like they don't have to go and write a note necessarily about what they did. They can just do this charting by exception one for neuro. Let's say like someone who's intact, you could just write intact, sign your name, and then that's your
Exactly.
focus assessment.
Yeah, I mean, that in itself is charting.
Yeah, so it doesn't mean having to write out a whole
No.
blurb on everybody.
Right, and like Jessica said, sometimes just that if the patient's pretty stable and all you did was you saw the patient in the morning, you saw that he was breathing, you saw that he was neurologically fine, then you just, either just check mark or whatever the signature to show that you interacted with that patient and you did do an assessment. And the ADL flow charts help to minimize the charting, and the PTIs later will help to keep the flow going in the continuation of the patient's care. Okay, I have 4 case scenarios to go through. First one, what time is it? Do I have time?
Your turn.
Okay. Mr. B has a tracheostomy and a drop-off with feeding at 90 cc's an hour. Early in the morning, the patient was nauseous and vomited 200 cc's. Bravol was administered with good relief. It is noon, and the LPN tells the RN that the patient is having difficulty breathing. Respiratory rate 20, O2 sat 87, BP 150/80, pulse 90. She noticed an increase in secretions via the trach and describes them as being viscous and milk-like. What should the RN do? Explain the next steps. So the LPN comes and tells you the patient is.
The RN has to take over, because
Right.
in this case, the LPN, you can delegate her to do other things, but you have to reassess again and come with a plan, like telling the doctor or add more oxygen or, So, the RN is taking over.
Anything else, Sunny? Okay, so let's go on. The RN should go and assess the patient herself. She doesn't need to repeat the vitals, but she needs to see the patient and the secretions. She needs to collect the data before calling the doctor. Maybe a chest x-ray is needed, maybe the patient has aspirated. If it's a ventilated patient, the LPN may not suction, but she can stop the feeding, she can auscultate, and she can medicate with the approval of the RN because the patient is now unstable and the RN says to go ahead to medicate. The RN should commend the LPN for coming to see her. The RN could delegate to the LPN to check on the other patients while she herself does the suctioning. Second one. It's 4 o'clock in the afternoon. An incident report is being filled out by an RN as Mr. X missed his 12 o'clock dose of Piptazo Q6 hours because she was not notified by the LPN that he was on IV antibiotics. The LPN is certain that she told the RN that he would have to receive a dose of Piptazo at noon. They begin to argue, and the RN shouts out, "I really do not understand why we need nursing assistants since their arrival. I feel as if my work is somehow duplicated." What do you think?
Well, I don't know.
Comments? Observations?
So I mean, this case should have been reviewed by both people in the morning, right? And are you reviewing as a group all the CMARs to know if there's antibiotics? If the nurse delegated to that LPN to be responsible for medication, then the LPN should come back to the nurse and say, well, wait a second, there's an IV antibiotic.
Yeah. So.
Problem with communication, obviously.
So the LPN is not responsible for telling the RN what to do. The RN is responsible for the overall care of the patient. The LPN can tell the RN there is an IV antibiotic, but it's not required. This kind of situation can arise when the RN and the LPN each have 4 patients to care for. But when all 8 patients are shared, the RN will be more aware of all the medications that are prescribed to their patients. Because then she won't say take care of that patient and all the meds associated with it. And just to say that this format of having 8 patients and 2 nurses kind of works better to avoid this kind of situation.
And I know that it is a feeling that I think a lot of people have, especially at the beginning, that their work is heavier, their charting is heavier, their responsibility is heavier, that's a lot of extra work. I know from speaking to some people in the French system, now that they've well integrated LPNs, they wouldn't go back. They find that, in fact, it's better, that it's more people to help. If your patient's not doing well, it's someone that will be in the room with you. You don't have to go and find someone. I think also to have someone, and I think the time too, if someone is doing more of the practical skills and you have someone who can sit back and now as a nurse have more time to think about the whole case and say, oh, okay, hold a second, maybe I'm missing this. You don't get that much reflective time when you're running to do tasks, actual tactical tasks, so they don't have time to think about the cases.
Yeah.
So I know that is something that's a concern at the beginning, and then when it's well integrated, when you trust the LPNs that you're working with.
So it
and
gives you
that can
time
be-
to plan more for the next step for the patient, and to have any family meetings that you may have to have, frees you up for that, for the nursing job. Case scenario 3, it's 10:45 and there's an order from Mr. J to receive 1 unit of PRDC. Mr. J has been assigned to the LPN since yesterday as he's a stable patient. The RN confirmed the presence of a signature on the consent form, verified the blood product with the LPN, and initiates a transfusion. Vitals are 125/72, 84 pulse, 60 respiratory, 98% room air, and 37 temperature PO. At 10:55, the LPN decides to do another set of vitals for Mr. J. He states, "I'm not feeling well," as he begins to retch and shiver. She presses the call bell, stops the transfusion, being aware that this might be a transfusion reaction, and connects the saline. Vitals are now 100/66, 110 pulse, 22 respiratory, 98% room air, and 38 temperature. So what are the issues here, and how do we react?
The nurse should have stayed for 15 minutes. It has
Exactly.
not been 15 minutes yet.
Right, exactly.
Also, I'd say the presence of the signature doesn't mean that it's necessarily the right person's signature either, right? You should know whose signature that is on the form. Because if it was an LPN or if it was someone else who signed it on the consent form, you should do it with someone else. You should know who it is.
Yeah, it's true. It didn't look like she tried to find another RN to verify it with.
But that's definitely the main one, is
Yeah,
like
definitely.
you said.
Quick on that.
I also have a question because here, is she shouldn't do it, but I remember on the previous slides that she's not supposed to discontinue the. So let's say we are doing that after 15 minutes, she can take over, so that she can see that there's a reaction to the blood transfusion. So she has to leave the bedside, go call the RN instead of just stop this and, instead of the reaction going for a minute.
Or she could pull the emergency bell.
So she cannot stop it.
So it seems silly, I can't press the button to stop it when I know it looks
Something
like a transfusion
wrong?
reaction, yes. So technically, that's what it is. If it's an LPN with experience, chances are she's gonna stop the pump. Chances are good she's gonna do it. However,
She's
it's
not
not
supposed
within her
to.
scope of practice. And so if it doesn't happen, we can't blame the LPN for doing that. Her role right now is to go get help. That's within her scope of practice, is to go get help, whether it be pulling the emergency bell, which is probably the best thing to do, to stay with the patient and pull the emergency bell. But that's her role right now, is to go get help. So you can't fault her for not pressing the stop button.
I guess you don't want people to stop it. Let's say they say, oh, they stop and then they leave and they're
Yeah.
trying to find you and they stop at the bathroom and they have a conversation in the hall and then forget and then it coagulates. Then that's bad.
why we say
Yeah.
they shouldn't stop or discontinue it.
Yeah. So if we go.
But I agree that it's very frustrating that they can't just push stop.
Yeah. Yeah, it's very.
Because me, I'm just focusing on the reaction
The
part. The
patient.
patient might be
Yeah.
swelling and difficulty breathing, okay, the RN is all the way there to K1. I don't know if you guys know the unit. Then I'm gonna be blamed because I wasn't in the right spot at the right time.
Right. So their
Is that-
role right then in that situation is to, alert, get the attention. That's their role.
Could you have an understanding between you and the LPN? Like, say Lisa's really worried and she's got a patient that's like so, and is not doing well to begin with. She says, I've done my 15 minutes, everything looks good so far. If you see something, if he starts to to stop it and then run and grab me right away. Is that okay? If she says like, can you just push stop on the pump and then immediately pull the call bell and I'll come running? Like, use an understanding between the two of you that's,
Because
Should
it's
not,
not
right?
within their
Yeah.
scope of practice, no, we should not be telling them to press the button.
so we should tell them to pull the cord
Yeah.
out of the wall
Yeah.
so that the fastest,
And because it may not necessarily be you, the person somebody else might be walking by, another nurse might be walking right by the room, and that's the person who's the fastest, who's able to get there the fastest. So pulling the emergency bell
is the
in
best
that case is
response.
actually the best response.
Okay. Yeah, so here it is. The RN is not present for the first 15 minutes, and the LPN cannot do the observation for the first 15 minutes. And the LPN cannot stop the transfusion, even if she suspects a reaction, but she can pull the call bell for a faster response. Last one, Mrs. Z is 78 years old. She's bedridden, has a coccyx wound. In the PTI, it's written, coccyx wound stage 2, no discharge, size 1 inch by 1 inch. In the wound care flow sheet, the treatment is as follows. Apply ProShield cream TID plus PRN. Change patient's position Q2 hours, give instructions to the PAB. The LPN observes that the coccyx wound has a light to moderate amount of yellowish discharge, and the dimension of the wound now is 1.5 inches by 1 inch. How should the LPN intervene in managing the wound of that patient? What is the role of the RN in managing the wound of the
And to
patient?
reassess the wound because there's a change.
Mhm.
The wound bed changed and there's discharge now, so
Mhm.
our aunt has to do the initial assessment for the.
Yeah.
You're a pro.
I'm
trying.
Yeah, you know
That's
Not
everything.
really,
She's got
I'm
all the
trying.
answers.
Bang, bang, bang.
That's good.
LPN has to notify the nurse about the change in condition of the wound. Write in the charts, so there's the documentation, the change observed, and that the nurse is notified. Apply any new directive for wound care then and document that. And she may modify the Cardex once the treatment plan has been established or authorized by the RN. The RN has to evaluate the wound, decide for the new treatment for the wound care. It could be to replace the ProShield by Mepilex with a border to absorb the exudates, and she will also document in the chart regarding the change in the wound and the wound treatment. And the LPN can contribute or suggest changes to the PTI. The RN must modify the problem directives in the PTI and wound records, the stage size and the exudates. So the LPN cannot make changes, but she can suggest changes, and they can share and keep that ongoing loop of communication going between them. Key things to remember: LPNs and RNs collaborate together to support the overall care of the patient. LPNs observe, collect data, and report observations to the RN. The LPNs cannot initiate, modify, or adjust orders, especially not without the RN's authorization. And the LPNs are accountable for their actions within their scope of practice. These pretty much cover broad. Any other questions later, we can always